بسم الله الرحمن الرحيم. السلام عليكم. أنا عبد العظيم عبد الرحمن، consultant psychiatrist في بريطانيا. الحقيقة قبل ما أبدأ البرزنتيشن بتاعي، عشان الناس ذات دي فرصة للناس تخش، داير أدي فكرة سريعة عن الحاصل في السوداني سايكاتريك كلوب اللي هو بدينا. هنبدأ ناخد بروجرام كل جمعة الساعة 10 بتوقيت السودان، وحنبدأ الليلة الليكشر الأولى اللي حقدمها عليكم عن treatment resistant schizophrenia. الأسبوع الجاي حيكون في الزميل الدكتور أحمد الأبوابي consultant psychiatrist السودان، هيقدم mindfulness as a core concept in current psychotherapy. الأسبوع اللي بعده يوم 7 أبريل دكتور هويدا عباس هتقدم child psychiatric case. وعندنا في الأسبوع اللي بعد ذاك 14 of April CBT approach in depression and anxiety دكتور ناهد الحسن. 21st of April 2017 dementia diagnosis دكتور محمود سعيد بشرى أو محمود بشرى سعيد. 28th of April internet addiction دكتور مجدي إسحاق. 5th of May 2017 psychodynamic formulation direction and action دكتور جمال هلال. 12 of May دكتور أحمد إبراهيم حيقدم اللوائح التفسيرية والتنفيذية لقانون الصحة النفسية السوداني. يا جماعة إذا الصوت ما واضح الناس تنبهني. أهلا يا محمد إبراهيم، محمد حسن ومحمد حسن فرج الله، مرحبا بكم. وماريا كيف أحوالكم؟ آخر لكشر هتكون 19 of May occurrence of priapism on low dose of quetiapine، دي حقدمها لنا دكتور محمد فرج الله. بعد ذاك رمضان طبعا هيبدأ، فغالبا هناخد بريك في رمضان. المهم ممكن نشوف في رمضان إذا في إمكانية نعمل حاجة، ممكن إذا ما في إمكانية بناخد بريك نواصل بعد رمضان. البرنامج ده طبعا مفتوح لا يزول، ما just for senior psychiatrist for everybody. you are very welcome. انك ان شاء الله لو عندك يوم واحد بس في السايكاتري you are very welcome انك to contact me عشان to present anything عنده علاقة بالسايكاتري. طيب انا حابدا طوالي عشان حقيقة انا داير الناس تلتزم بالزمن. الساعة 10 قلنا نبدأ طوالي. بسم الله الرحمن الرحيم. I will start my talk now. The treatment resistant schizophrenia. Okay. What we know about schizophrenia. In my lecture today I will talk quick history of schizophrenia, and then we'll touch on the clinical features of acute and chronic schizophrenia, and then we'll talk about treatment resistant schizophrenia and the treatment for that. If we look for the history of schizophrenia quickly, it's all started in 1800. Somebody called Grissner, he called all mental disorders are unitary psychosis. And then 1852, a psychiatrist from our doctor actually from France called Morel described a disorder with social withdrawal and odd mannerism and self-neglect. He called it as démence précise, which is a French word. And then in 1863, Callahan come and described syndrome of catatonia. And then in 1871, Hecker described the syndrome of epiphrenia. So catatonia is the first category of schizophrenia being described. And then came the famous name Kriblin in 1891, and he divided mental disorder to something called dementia precox and manic depressive psychosis. And then in 1990, He divided dementia precox into catatonic, hypophrenic, paranoid, and simple. And then in 1908 came the famous name, which is Boiler, who proposed the name schizophrenia. So the name schizophrenia came in 1908. And then came, of course, Kurt Schneider, 1959, a German psychiatrist. He identified group of symptoms to diagnose schizophrenia. I call it first rank symptoms. And these symptoms was the base for ICD-10 criteria. In 1985 came Crew, who is a British psychiatrist. He described two syndromes of schizophrenia based on a combination of clinical and neurobiological factors. He call it type 1 or type 2 schizophrenia. He said type 1 is acute onset, positive symptom, preserved social functioning, good response to antipsychotic, dopamine hyperactivity. And type 2 is like the chronic type of schizophrenia, which is insidious onset with negative symptoms like apathy and lack of motivation. And this type, he described it as having poor response to antipsychotics. And usually there will be structural brain changes, ventricular enlargement, and there is no evidence of dopamine overactivity. Of course, now we know more about schizophrenia, and tend to be this views of Cruz was being disputed, because it's true about type 2. When people get quite chronic in the illness, in the course of illness, they have structural changes, but there is evidence of dopamine overactivity on it. And then comes ICD-10, which is the International Classification of the Diseases, and the DSM, which is the American classification of the mental disorders. The ICD-10 put some criteria. It put a period of at least 10 months of the, at least 1 month, 1 month of the following: thought echo, or thought insertion, or withdrawal, and thought broadcasting. And this for people who are new to psychiatry, because I knew there's a few people here that are not psychiatrists. Thought echo meaning that the patient is hearing his own thoughts, the voice of his own thought. Thought insertion, he believes that somebody inserted thoughts in his mind. Thought withdrawal, the patient believes that somebody took thoughts out of his mind. And thought broadcasting means that he believes that his thought is being broadcasted among people, or other people knows what he's thinking. This delusion of control, influence of passivity, and this is quite characteristic for the schizophrenic patients. Very unlikely to find other patient having this kind of delusion like depression. So if you have a patient with delusion of control, that's most likely the schizophrenic patient, which is a belief that his body is being controlled by external forces. Commentary hallucinations is one of other feature of schizophrenia, which is a patient hear voices commenting his action. Persistent delusions of any kind, like paranoid delusion, persistent hallucination of any kind, thought disorder, catatonic behavior, and negative symptoms like apathy, emotional plump, and significant changes in the overall quality of life. So that's the main features in ICD-10. The DSM criteria put more like 6 main features: delusions, hallucinations, disorganized speech, grossly disorganized behavior, and negative symptoms. And 2 or more of this following should be present for a significant portion of time during 1 month period. So some people prefer to use the DSM, some people prefer to use the ICD-10. Okay, so after you diagnose schizophrenia, we come to the treatment now. So what kind of treatment you will consider? Of course, you give the antipsychotic treatment, and there's like 3 types. There's first generation, which is older antipsychotic, and there's the second generation with the atypical antipsychotics, the newer one, and there's a long-acting depot injection, typical and atypical. Usually, you start with the second generation. The first generation includes chlorpromazine, which is chlorpromazine is considered as the first antipsychotic to be discovered in 1952. And actually, when it was discovered, it was a revolution in psychiatry, because people tend to stay in institutions and hospitals for a long time before discovering of chlorpromazine. And then when the chlorpromazine was discovered, it led to let people treat a lot of patients and being discharged from the longer institute into the community. So it made a big difference to the lives of a lot of patients. The other one from the first generation, which is quite famous and we still use it, is haloperidol. But these days we use it mainly for manic or bipolar illness rather than schizophrenia. Sulpiride is another first generation, which is widely used, and trifluoropyrazine. Of course, there's some problem with the first generation, more severe side effect, more castrate-pyramidal side effect, like cachexia, tardive dyskinesia, and stiffness. But the second generation came late after that, which is olanzapine, quetiapine. They came on late 80s. They started, or in the 80s, and then on the 90s, most of them was in the market, which is olanzapine, quetiapine, risperidone, amisulpride, and then riprazole and clozapine. Clozapine is a different story. We'll talk about it in a minute because it's older than all that, this medication. So the second generation is usually considered the first line of treatment in schizophrenia. So if you diagnose somebody with schizophrenia, it's preferably you go for the second generation. There is no preference between them. All the studies show that they are equal in the efficacy. But you can choose the patient depending on the patient. Some patients may be suitable to start them with olanzapine, especially if they are slim. They're not like overweight, they're slim, non-diabetic, and having people with sleep problems. So it's better usually to start olanzapine. Because one of the causes of side effect of olanzapine is obesity and drowsiness and diabetes. And then risperidone also, you can choose it for people if you are worried about weight or they are overweight, then you can start risperidone. Quetiapine is another one, and amisulpride and aripiprazole, which is Abilify. There's a depot injection, or was a long-acting depot injection, which we usually use it for people who disengage from the surface, or they don't like taking oral tablets, or difficult to maintain compliance with oral medication. So you start depot injection, and this type of injections like clobixol, dipexol, and Modicate, that's the oldest generation. Haloperidol injection, usually you give the injection 1 or every 2 weeks. And then came the new injections, risperidone, which you give it every 2 weeks, olanzapine, paliperidone for every month, or aripiprazole every month. Okay, the key point of treating people with schizophrenia is that the patient should know, and the relative of the patient, they should know that antipsychotics do not cure schizophrenia. They just treat symptoms. So in the same way that insulin treats diabetes. So there is no cure for schizophrenia, but we usually give the antipsychotic to control the symptoms. And for that reason, I think we should advise our patient that the treatment usually is long term. It's required to prevent relapse. And because this is a common question, usually the patient and the relative ask how many for how long do you think I should take the antipsychotic? And I usually advise them it's better take it as long as it take, because the more you take it, the chance of relapse will be less. So usually you should discuss the side effect with the patients, and you find the best tolerated drugs that can be given to the patient. And never stop the antipsychotic suddenly. Usually, if you want to stop any antipsychotic, try to do it gradually. So the clinical scenario usually, or the journey of the schizophrenia, is patient you've been diagnosed with schizophrenia and start the antipsychotic. Okay, if there is no adequate response to the initial trial of antipsychotics, let us, for example, say that a patient can be diagnosed with schizophrenia, you start olanzapine, and you reach the maximum dose, which is 20, and he has to stay for that in about 6 to 8 weeks. So after 2 months, you see the patient again, still there is no response, or there is no remission of the symptoms. So you should check these steps first. You should ask yourself, is the diagnosis of schizophrenia is correct? And if it is correct, is there any relevant comorbidities? For example, is there any depression or anything like that? And then if you are sure the diagnosis of schizophrenia and there is no relevant comorbidities like depression or anxiety or anything, then you should ask yourself about the possible non-compliance in terms of medication take. And then you should ask yourself about, was the sufficient dose of antipsychotic being achieved? And was the duration of the treatment sufficiently long? As I said, usually 2 to 4 weeks for when you start, and then you give up to 6 to 8 weeks. And if that's the case, the patient is schizophrenic, you give him the diagnosis right, he's taking olanzapine, there is no response, he took the 20 milligram for enough time, and you make sure that he's being compliant with the medication. Usually in Sudan, it's very easy to check that because the relative usually, which is good about Sudan actually, the relative of the patient, they're usually involved in the treatment. So you can check that with the relative if he's been taking the medication. If he's been taking the medication and on the maximum dose or the enough dose, and there is no response, then you have 2 options. You can either switch to another antipsychotic. So you choose one of those antipsychotics and give it another try with that. Or sometimes you can give high dose of the same medication above the prescribed dose, but there is no evidence for that. We'll talk about that later, but there is no evidence of that. So usually people try another antipsychotic, and then they try a third antipsychotic, and then by a few years, if there is no response, then they will thinking of other option. But the ideal good clinical practice is that use one antipsychotic, as I said, for 8 weeks. It's no response, use another antipsychotic. If there is no response, look for the duration of the illness. If they are not functioning well for the last 3 or 4 years and been like that, then it is time for you to switch to clozapine. Okay. Sometimes out of desperation we tend to use more than antipsychotics, and we use like 2 antipsychotic or 3 antipsychotic, and this is very common practice. But all substantial evidence suggests that polypharmacy is harmful, and there is little evidence that supports the efficacy of combined antipsychotics. So if you're giving 2 antipsychotics or 3 antipsychotics, you think that you are treating the patient effectively, but actually there is no clinical evidence that or research evidence that it will work. Some people also use high dose. What I mean by high dose is above the normal dose or above the recommended dose. For example, if the olanzapine is 20, some people use 30 or 25. Again, there is no firm evidence that high dose of antipsychotic are any more effective than standard dose. But from clinical practice, we notice that sometimes it can work, especially in some challenging cases. So you can use high doses, but you have to ensure that sufficient time has been allowed for response. You have to make sure that at least 2 different antipsychotics has been tried. You have to make sure that you used clozapine and failed, or the clozapine can fail, maybe is not effective or not tolerated or develop side effect from clozapine. And then you try to adjust treatment with other. Sometimes you can use other medication with antipsychotic like antidepressant or mood stabilizer, but there is no evidence, research evidence for that. Okay, any patient who's in antipsychotic medication, we should do regular physical monitoring, because most or many psychotropic drugs are associated with ECG changes, and it's probable that certain drugs are cause serious ventricular arrhythmias and can cause sudden death. So the mechanism of that, the antipsychotic usually block the cardiac potassium channels, and this linked to the prolongation of cardiac QT. So the QT interval usually prolonged by antipsychotics because antipsychotics block the cardiac potassium, and that increases the risk for arrhythmias and sudden death. So if you start any patient with, ideally we should do a baseline ECG and then repeat the ECG again in about a few weeks. If there is any problems in the ECG, then we should consult our colleagues, the cardiologist. Okay. The QT prolongation, I mean, as a psychiatrist, most of us are quite ignorant of reading ECG, and I am one of them also. But the things that we can read from the ECG is a QT. So you find this QT, and then there is a number beside it. And usually for men, the normal limit is 440, and for women, it's 470. So if you start somebody with antipsychotic, look for this QT, even if you don't know how to read the ECG. And then if for example, if the patient is man and the QT is more than 440 but less than 500, then you don't do any action. You just wait and observe. And again, for female patients, if it is between more than 470 but less than 500, no action required. But if or you can actually sometimes some people recommend that you can reduce the dose and switch to another antipsychotic, but this, or you can just observe it and repeat ECG again after 4 weeks. But if the QT interval jump to more than 500, then you should stop the antipsychotic medication and refer to cardiologist immediately, because as I said, the risk of that is a sudden death. Arrhythmias can happen and patient can just suddenly die, and it happens for a lot of patients that they just suddenly die while they are on antipsychotic medication, and the reason for that because of abnormal QT interval. Okay, so as we said earlier, if you start medication and then to antipsychotic and both failed, then we need to go for clozapine. You need to diagnose a patient with what we call treatment-resistant schizophrenia. And the definition of that patient with schizophrenia who, despite at least 2 adequate trials of classic neuroleptic drugs, have persistent, moderate to severe positive or disorganization or negative symptom together with poor social and work function over a prolonged period of time. So you usually look for the patient, give the first antipsychotic, fail the second antipsychotic, and look for the history of the patient. If he's been ill for a few years, 3 years, 4 years, then that's time you go for you diagnose the patient as having treatment-resistant schizophrenia. These 2 antipsychotics, one of them must be atypical, so you can have, if you have in olanzapine, and the other one can be typical or atypical. Yeah. So one of the, you have to try him with atypical before you start clozapine. So if a patient having 2 drugs from the first generation we mentioned earlier, like chlorpromazine, haloperidol, for example, you don't diagnose them with treatment-resistant schizophrenia unless you try one of the atypical medication. And unfortunately, about 30% of schizophrenic patients meet the criteria for treatment-resistant schizophrenia. The remaining 70% usually respond to the antipsychotic. Some of them, they may still have negative symptoms. But the 30% of schizophrenic patients, they don't respond to the normal antipsychotic. When I say normal, it's just to differentiate it from the clozapine or non-clozapine antipsychotic. Yeah. The problem about schizophrenia is the lifetime suicidal rate, usually 9 to 13% schizophrenic patient. So it's important that we treat the schizophrenia quite effectively. So if you have patient and you need to assess if he has treatment-resistant schizophrenia, then you should review all previous medical notes for the duration of the symptoms. You see the medication tried, any side effects, any issue of non-compliance. Some possible non-compliance with the medication. Regarding medication, they may not be taking the medication regularly, so this not considered treatment resistant. They have to take the medication in order to diagnose them as treatment resistant. And then you take full psychiatric history, mental state examination, do any necessary investigations, and the idea of that is just to confirm the diagnosis of schizophrenia. And you check if they received sufficient antipsychotic dose for a sufficient time before you jump to a conclusion of treatment-resistant schizophrenia. If you're convinced that the diagnosis is right, schizophrenia, then you start the clozapine. So what's the clozapine about? The clozapine is a very interesting drug. Actually, it's an old drug. Actually, first it was tried in 1961 actually, first clinical trial in schizophrenia, but was withdrawn in 1971 because there was report of fatal cases of agranulocytosis. So the agranulocytosis drop in the count of the neutrophils, and the danger of that, when people have agranulocytosis, they will be quite prone to infections. And so there was a few cases of death happening in 1975 because of that, so it was being withdrawn from the market. But again, came to the practice, people start using it again in 1988, and that's after a study showed that it can be very effective in the treatment of schizophrenia. It's classified as atypical antipsychotic. The action of it usually bent to the serotonic and dopamine receptors, D1, D2, D3, but he has very high affinity for D4 receptors, usually more active in the limbic system rather than the striatal dopamine receptors. And that explains the relative freedom of clozapine from any extramyelin side effect. Partial agonist at 5-HTA receptors, and this deal with depression. This receptor is a serotonic receptor, so the clozapine also works on that, and that explains that clozapine can be also improve the depression and anxiety and the negative and cognitive symptoms of schizophrenia. And it can also bind to adrenergic or cholinergic or histaminergic receptor, and that's why it causes one of some side effect from that. The absorption is by first pass metabolism, usually goes to the liver and then metabolized in the liver and then changed to something called norclozapine, which is the active ingredient of clozapine. And this norclozapine is able to pass the brain barrier and go to the brain. There's other things that can affect the metabolism of the clozapine. Smoking can increase the metabolism of clozapine, so it decreases the plasma level. While there's some medication can decrease the metabolism and increase clozapine, such as fluvoxamine and SSRIs, they can do that. But all researches about clozapine shows that clozapine is superior to other antipsychotic medication in terms of efficacy. And there's a few studies like that. There's one study done in University of Wales, and the aim of the study was to investigate the use of clozapine in treatment of schizophrenia and to compare between clozapine and other antipsychotics in terms of the rate of hospitalization. And it shows that people who is on clozapine have very much low rate of hospitalization compared to other people who are on other antipsychotic medication. As we said, the main indications treatment of resistant schizophrenia. Sometimes some people use clozapine in other indications other than treatment of resistant schizophrenia. Some people use it in chronic cases of suicidal behavior. If somebody's been having suicidal thoughts or suicidal risk for a long time, it shows that clozapine can work with this type of group. In secure wards and hospital and units, they use clozapine a lot to treat severe personality disorder and antisocial personality disorder, and it proves that it can reduce the rate of impulsivity in this kind of patients. But there's also some contraindications. If the patient is epileptic with uncontrolled epilepsy, then it's better not to use clozapine. If they have history of agranulocytosis or any blood diseases, it's better avoid clozapine. If they have pre-existing cardiovascular, severe cardiovascular illness or history of arrhythmias, then it's better not to use clozapine. And of course, if there is controversial studies about clozapine in pregnancy. There is no evidence that it can harm the baby, especially after 3 months. And it happened that I had a patient like that. She was pregnant on clozapine, and she did not want to stop the medication, so we have to continue on clozapine while she's pregnant, and she delivered the baby, the baby was fine, but usually it's contraindicated in breastfeeding. Okay, so that's clozapine. As I said, there's some things that can reduce the plasma clozapine level: tobacco and smoking. They can do because they cause enzyme induction, and cannabis smoking also. So people, when they smoke, this reduces the clozapine level, and because the metabolism will increase in the liver, and that this kind of people, they need usually higher doses to achieve the effect. Caffeine also inhibits the metabolism of clozapine and increases the plasma level. So just to be clear, smoking reduces the plasma level because it's induced the metabolism, increase the metabolism. Caffeine, on the other hand, inhibits the metabolism, so the plasma level increase. So if people have clozapine and they drinking a lot of coffee, then you may expect to have side effect from the clozapine. So you need to advise them to cut down their caffeine drinking. Lithium also increases sorry, not lithium, I mean phenytoin, decrease the plasma clozapine level. Anticonvulsants. Benzodiazepine is another story because that's common drugs we use a lot, like diazepam and things. So if somebody is on clozapine, it's better to avoid using benzodiazepine because it increases the risk of circulatory collapse. So it's better not to use, or if you use it, just use it quite cautiously with a small dose. Clozapine has side effects as general, the hematologic, cardiac. This common side effect usually happens with clozapine. Hypersalivation, people usually have a lot of saliva. Fatigue, sweating, it can happen. Weight gain, it can happen. But one of the common side effects is also drowsiness and tachycardia, because usually the pulse become quite rapid. But the plus side effect is leukopenia, eosinophilia, leukocytosis, but the most fatal one is agranulocytosis. And it is a low neutrophil count, as we said. It occurs about 20% of patients who take clozapine during the first few months. And then the risk of developing it is higher, about 3 months to treatment, and decreases substantially after that. It becomes 0.01 after 1 year. Of course, if patient experience agranulocytosis, then we should stop the medication, the clozapine. The warning sign of agranulocytosis is sudden fever, chills, sore throat, weakness in your limbs, sore mouth and gums, mouth ulcers, and bleeding ulcers. So if you have this kind of things, that indication there is infection going on, then you should immediately do a blood test. And if you find the WBCs is low, the white blood cells, then you immediately stop the clozapine. Clozapine can cause this cardiac side effect, but it's not that common. But the most common is tachycardia. Usually you will notice the pulse rate is quite high, 120, may reach more than 120. ECG changes, hypertension, arrhythmias, myocarditis, but very rare, can cause myocarditis and can cause cardiomyopathy. So you should, when you start somebody with clozapine, you should do an ECG before you start the clozapine, and then 3 months after that. And if it is normal, then you can do it every 6 or 12 months. If this ECG showed any abnormality, then you should refer the patient to the cardiologist. There is some gastrointestinal side effect, constipation, nausea, vomiting, but it's not that continuous. Okay, so one of the side effects of clozapine, which is also serious but not common, is the seizure or fits. So if there's seizure or fits happen due to the clozapine, then we should stop it for 1 day, restart it as low dose, and start sodium valproate with it. Okay, so what you do before you start patient clozapine? You consult the patient and their relative. You give them information about clozapine. Ideally, it depends on where you work, or but if the patient can sign a consent form, that will be fine. But it depends on the practice in the area. But you should do full blood count, physical health check, and physical examination, and ECG, as we said. And then if all the investigation is normal, then you should admit the patient to the hospital to start the clozapine. It's very dangerous to start it in the community. It's better usually admit the patient to start the clozapine, admit the patient to the hospital. During admission, blood pressure, pulse, and body temperature should be checked every 6 hours. The starting dose is usually small, 12.5 milligram. You give it once in first day, then increase it slowly to 12.5 first, then 25, then 50. Maximum dose is 900. After 1 week, if his observation level is all normal, then you can discharge the patient. After discharge from the hospital, you need to regularly monitor the blood test. So usually you monitor it every week for about 18 weeks, and then after that every 2 weeks from 19 weeks up to 52 weeks, and then after that you just monitor it every 4 weeks. And then you continue monitoring every month the blood test. If the patient develop agranulocytosis or the white blood cells dropped, then as we say, you discontinue the clozapine immediately, and then you admit the patient to the hospital. You shouldn't start the clozapine again. Okay. There's 4 groups of patients after you start the clozapine. There's group 1, which I call the happy group, patient responding very well, tolerating clozapine, no problems. That's about 70% of people. Group 2, patients start responding but experience side effect and unable to tolerate it after certain dose. And this is like usually notice that dose will be about around 200. When they start on 200 milligram, then they start having problems and side effect and drowsiness, complaining that they can't continue like that. So, or they may have fits or seizure. So what you do in that case is a very challenging clinical problems. You continue with a small dose of clozapine, but you augment it with another antipsychotic medication, usually amisulpride, sulpride, aripiprazole, risperidone, lamotrigine, haloperidol. Try to avoid olanzapine, because olanzapine and clozapine together can cause diabetes and other physical problems. Group 3 patients, they tolerate clozapine very well and on high dose, but still there is no problem, no improvement. And this group, I think you need to review the diagnosis again. Maybe you are not treating the right diagnosis. Maybe it's not schizophrenia. If you are sure about the diagnosis that schizophrenia, and you increase the clozapine up to the maximum dose, 900 milligrams, still there is no response, then you need to augment it with another antipsychotic, maybe amisulpride. And then group 4, which is usually patients respond very well, they're free of symptoms, and they continue like that for a few years, carry on with their life, very successful treatment, but then develop agranulocytosis after 4 or 5 years. This is a very challenging problem actually, because they develop something called refractory schizophrenia. So when you stop the clozapine, they become quite psychotic, and then you have to use other medication like oral or table. You have to combine medication. The success rate is usually very poor. So you admit them, you start another antipsychotic, and you try to see if it helps. If it not, then you can add another antipsychotics. You treat them with 2 antipsychotics. In the meantime, you continue monitoring the WBC count. Usually the agranulocytosis, which develop after clozapine, is reversible. So after a few months, the WBCs should go back to normal. If there is no response from the other antipsychotic, then you can re-challenge them with the clozapine again. But before that, you need to do full blood count, and you need to start them with lithium. So you start lithium 400 milligram and increase the dose until you have a plasma level of 0.4 of lithium. The idea of starting the lithium is that for an unknown mechanism, the lithium known to increase the WBC's count. So the lithium will increase the WBC's, the white blood cells count, and then you can start the clozapine. But again, if you develop a granulocytosis, that's another story. Then you have to stop the clozapine, and you have to restart again other antipsychotic, and then you have to just forget about the clozapine. So that's in summary, how do you treat treatment-resistant schizophrenia. It's just quick summary. You need to review all medical notes and antipsychotic been used before. Of course, you need to take full history and confirm the diagnosis. Explain to the patient, carry about clozapine. Admit the patient. You have to admit the patient to the hospital. And stop all psychotropic medication. Then you do full blood count, ECG. You start clozapine with small dose, increase gradually, discharge after 1 week or 2 weeks, and then follow in the community and do the blood monitoring regularly. Okay, thank you very much for your listening, and I will take some question then. I will just look at the question. I have to wear my glasses. Okay, so I will just try to start from the beginning. Mujtaba Usman, how about combining taboo and oral antipsychotics? As I said earlier, there is no, from research point of view, there is no evidence that combining 2 antipsychotics will work. You shouldn't give a depot injection unless if the patient is not compliant with oral medication. So it's not there's no evidence for this practice, but however, we all do it. We sometimes do that. We give, especially if the patient is already in table and they are not responding well, we can top up that with oral medication. Like if the patient is in risperidone, then you can risperidone injection. Then you can start risperidone oral on top of that. But that, as I said, there's no research evidence for that. Okay, Maria, regarding old age and use of risperidone, it has been said that it is cause of sudden death. Do you suggest any other antipsychotic? That's a good question, actually. I think the risperidone, the problem with risperidone and old age is increase the risk of stroke usually. The best medication for old age is aripiprazole. Actually, it's called Abilify because it doesn't cause this kind of nasty cardiovascular causes. But risperidone, olanzapine, unfortunately, they increase the risk of stroke. But if the patient is physically healthy, then you can still start risperidone, but you have to do it a small dose. But as I said, the best medication is aripiprazole. Quetiapine may be maybe another option also for old age. معلش إيمان said الصوت واطي شوية. I'm sorry for that. تبع ECT can be useful in clozapine resistance. Well, that's a good question. It can work in some people, but not most people. Usually work with people who's having depressive symptoms or having affective symptoms with the illness or aggressiveness or something like. But it doesn't treat the illness itself. So it can be useful for short period, but not for long period. I don't know if there's any question else. I'm just looking for that. Okay, I think if there's no question, then we'll stop here. Just a reminder to the people watching all. Next week, Dr. Ahmed Al-Abwabi, he will present mindfulness as a core concept in current psychotherapy. I'm just trying to check so that I will not miss anybody who's asking any question. There's no question, isn't it? No. ECD useful. اوكي فواز بيسأل هل الفيديو حيكون محفوظ؟ ان شاء الله. I think so يا فواز، حيكون موجود في البيج. As I said, الفيديو حيكون موجود في البيج. If you have any other question, I will be glad to answer it on the page. And next week, Ahmed Al-Abwabi, same time, mindfulness as a core concept in current psychotherapy. شكرا جزيلا لاستماعكم، وأتمنى أكون ما أصغلت عليكم. شكرا جزيلا، مع السلامة.